call upon Dr. Toshit Varshni. His presentation is on staged surgery approach for intractable hemorrhage during diabetic vitrectomy.
Good afternoon, everyone. I'll be talking about staged surgical approach for intractable hemorrhage during diabetic vitrectomy. We have no financial disclosures. So intraoperative bleeding is a major challenge in diabetic vitrectomy, and it precludes the membrane peeling on the posterior pole. Even after injecting preoperative bevacizumab, up to 30% of the eyes can have severe intraoperating bleeding, and if the time is delayed for the surgery, it can even lead to VEGF crunch. When bleeding happens, most commonly surgeons use increase in intraoperative pressure, but in diabetic patients we have to be careful because they already have a low mean arterial pressure for the ophthalmic artery, and a prolonged rise in IOP can cause disc pallor. So the objective of the study was to evaluate the outcomes of a staged surgical approach where intraoperative bevacizumab and sulfur hexafluoride tamponade was given for eyes undergoing diabetic vitrectomy for TRD, which were complicated by intractable intraoperative hemorrhage. It was a retrospective case series. Single surgeon cases were taken with an experience of more than 20 years, and eyes with tractional retinal detachment, including combined mechanism detachment, were included. So all the eyes which had intractable hemorrhage on table, that is an insufficient hemostasis after multiple attempts of controlling the bleeder, that is by increasing IOP, using endodiathermy or use of PFCL, which led to blood clots that were on the posterior pole, and they precluded complete membrane dissection and endolaser. These eyes were closed under 1.25 milligram of 0.05 ml bevacizumab and 2 ml of 100% SF6. On post-op day 15, they were evaluated for presence of retinal detachment, or if there was any dense vitreous hemorrhage along with presence of traction on B scan. They underwent a second completion surgery where silicone oil injection was done. If this was not present, then these eyes were observed, and if there were any gap areas, they underwent add PRP later on, or break underwent barrage laser. Outcomes that were assessed were absolute success, that is the retina was attached without any tamponade. Relative success were complete retinal attachment under silicone oil tamponade. So in the period of 2 years, 980 eyes underwent surgery, out of which around 165, that is roughly 20% of eyes, had this intractable hemorrhage. At baseline, the key features that were significant were that these up to 42% of eyes had bilateral severe visual impairment. The most common systemic comorbidity was hypertension. Anemia was present in 57% of eyes, and the median baseline HbA1c level was 10. So after the first surgery, 43 eyes didn't require a second stage surgery. Their best corrected visual acuity was 0.6 logMAR, and out of them, 9 eyes required add PRP, 11 eyes required barrage. 2 eyes had a rebleed for which they required repeat silicone oil injection. The factors that were associated with the requirement for second stage surgery significantly were lower age at presentation, higher duration of symptoms, and involvement of macula, that is MTRDs and combined mechanism RDs. After second stage surgery, the final best corrected visual acuity was roughly 6/60 in these eyes. Absolute success was seen in 68% of the eyes. Relative success was in 17% of the eyes. Failure rate was 14.5%, and 12% of eyes had neovascular glaucoma. So factors that were associated with a good visual outcomes were lower duration of symptoms, better baseline visual acuity, lower diastolic blood pressure. This is a perioperative blood pressure, and less number of MTRDs and combined mechanism RDs. On a multifactorial analysis and subgroup analysis, it was seen that duration of symptoms was the most consistent, most significant factor. So these are few representative images. Coming on to a discussion, compared to the national study that has been done, the patients in our group had a lower age at presentation. The hypertension was significantly the most common systemic comorbidity, and baseline HbA1c was high. Anemia has previously been seen to cause increased bleeding tendencies, but it has not been evaluated in a study with DR yet. Perioperative blood pressure, to the only study that has been previously done in DR eyes, our perioperative blood pressure was higher, but we can't compare these two studies as such. And these were the factors that have been seen in previous studies which affect the visual outcome and compared to our study. So limitations was it was a retrospective study and it was non-comparative. Coming to conclusion, we are saying that this is a safe approach for such eyes and it is a viable alternative and not the main line. When there is intractable hemorrhage, we can proceed with something like this. Thank you.
Good presentation. Can I ask you what is the rationale for putting that 100% SF6 on table in this vitrectomized eye?
Ma'am, I'll answer this in two parts. So previously, what has been mentioned in textbooks, especially Ryan's, where it says that more than 1.2 ml of pure SF6 should not be injected in the eye. That has been based on a study that was done in 1979 and 1985. Both those studies were done on rabbit eyes, and it was not a human study. Compared to that, recently we have already published a paper that I mentioned as a reference, where 75 eyes for macular hole, at the end of the surgery, we injected 2 ml of pure SF6 instead of the usual 18% concentration that we take, and none of these eyes had any complication. So as a part of our protocol in our institution, we usually inject 2 ml of 100% SF6. Also recently in 2018, a paper has been published in Ophthalmology Retina, where they have prepared eye models for human eye comparing different axial lengths, where they have found that if almost we inject till 50% of the vitreous cavity volume is injected with the pure SF6, it won't cause subsequent high rise in IOP. And when we are injecting 2 ml of SF6, we are also opening the infusion port. So it roughly comes out to somewhere around 40 to 45% of the vitreous cavity that is occupied by this SF6.
So this is injected in a fluid-filled cavity or in an air-filled cavity?
Air-filled cavity, ma'am.
Air-filled cavity.
Yes.
Okay. So the main thing is, if you are looking at this perioperative bleeding, your main intention of injecting gas or air is actually hemostasis. So you need an immediate pressure, increased pressure in the eye for hemostasis. So I don't know whether this, of course, if you are already done a air FGE, that will give enough pressure. So whether gas should be injected or not, that also in a surgery where the membrane dissection is inadequate, which carries a risk of developing iatrogenic breaks, because if there is already a break and the membranes are not completely removed, then you are putting the patient at a risk of developing further breaks.
Ma'am, the rationale for this was that a lot of cases before presenting the study, before starting the study, had bleed under the silicone oil, which required oil removal followed by again injection, and a very high intraoperative post-op IOP. So nothing like that was observed in this study. Another use for this was that sometimes the clots, usually they disappear by 2 to 3 months, but sometimes they act as a nidus for repeat fibrovascular proliferation and causing again detachment. So that thing was taken care of. And also at 15 days, when there was a redetachment, these cases were taken for a resurgery, and that time the bleeding was not significant and they could be closed in the second surgery.
What is your premise of using gas and anti-VEGF post-vitrectomy?
Sir, one of the premises that in our institution there is no protocol of injecting preoperative bevacizumab in the eyes, because a lot of these patients are systemically unstable and they are not admitted for those 5 days that we inject, and they are admitted for 3 days and then they undergo surgery. So that is not done. So we inject bevacizumab on table, so that post-op the membranes, the bleeding is less.
Is your study design will support your premise?
Yes, sir.
Is your study design support your premise? To test your question or whatever you are thinking, is it sufficient enough?
Sir, the other thing, according to a design, we should have a comparative arm, that eyes that didn't undergo second stage, that didn't have intractable hemorrhage, they should be compared. That is one of the limitations. That data collection is under
limitation. This is the
Yes, sir.
design that need to be
Yes, sir.
tested in your study.
Yes, sir.
So I want to ask you, bevacizumab was injected in all the 165 eyes,
Yes, sir.
despite them being, you're telling, so this whole study is based on preoperative non-injection of bevacizumab to these patients, predispose these patients to higher risk of bleeding, which is 165 out of 980, which is fairly high, and that is why you required a 2-stage surgery. So I would say, there is a lack of design probably here. I would say that the reason for the bleed is you have not injected them with preoperative, preoperative bevacizumab, which is now almost a standard in all these cases.
So to answer that question, so the second premise for the study was that when there is a lot of intraoperative bleeding and we are again and again increasing the IOP, we get a 100% anatomical outcome, but the disc has pallor in the postoperative period.
No,
The
that
other
would be
thing
there
is
in
we
this
have-
case or the other
Yes,
case.
sir. And we have conducted a smaller study in our institute, which I have not presented the data here, where 15 eyes that underwent two-stage surgery, they were given preoperative bevacizumab and they still develop intractable hemorrhage. I've also put a reference that up till 30% of eyes can still develop severe bleeding, and this was a 17%, 980 divided by 165, it is somewhere around 17%. It's still less than what has been published in literature. So out of those 15 eyes that had been given bevacizumab and still required second stage surgery, so that showed the patient profile has other risk factors which is predisposing them to bleeding on tables.
Okay.
Just one question. For those 165 cases, do you have data for those number of patients who had residual traction at the time of bleeding?
Yes, sir.
So, because if you compare the outcome, final outcome of the second stage surgery, some patients you told it cleared on their own. So, those who have residual tractions at the end of the surgery when the bleeding had happened, those are the ones which have supposed to have
Yes, sir.
poorer outcome and requires a second surgery.
Yes, sir.
So, do we have a data? Of
Yes,
that
sir. We
as
have.
well? So,
we
probably
have.
you can compare
Yes, sir.
that also. That will be more meaningful.